Assalamualaikum warahmatullahi wabarakatuh and a very good evening. Today I would like to share regarding alcoholic liver disease and malnutrition. I will start my presentation with a clinical scenario. A 42 years old man presents to the clinic with complaint of chronic loss of appetite as well as generalized body weakness that is worsening for the past 1 year. He has history of consuming 1 pint of whiskey every day for the past 10 years. On physical examination, the patient has tinge of jaundice on the sclera, proximal muscle wasting, as well as enlarged liver and spleen. Blood investigation shows that the patient has raised aspartate aminotransferase or AST, slightly raised alanine aminotransferase or ALT, as well as elevated bilirubin level. In this clinical scenario, the patient is suffering from alcohol liver disease secondary to chronic alcoholism with malnutrition. Alcohol is the most frequently abused substance for many centuries. However, it is not until 1960s that the alcohol was recognized to be directly hepatotoxic, meaning that chronic ingestion in an excessive amount will directly damage the liver. In the United States, about 60% of the general population reported some drinking, while about 8 to 10% reported heavy drinking. And the heavy drinker is defined as having 2 or more drinks per day, whereby one drink is equivalent to 12 ounces of beer or 6 ounces of wine or 2 ounces of whiskey. In Malaysia context, about 17.8% of Malaysian population are avid drinker, meaning that 17.8% of Malaysian had at least once in their whole life taking alcohol. In addition to that, about 11.6% of Malaysian population are current drinker, and the age of onset of taking alcohol is about 21 years old. According to Hatta and colleague in 2014, majority of the Malaysian population that consume alcohol coming from the Chinese background as well as other Bumiputras. And the lowest prevalence of alcohol consumption is among Malay population. Many studies have linked chronic alcoholism with various types of diseases, for example, hypertension, heart disease, alcoholic liver disease, dementia, alcohol dependence, various cancers involving breast, mouth, and gastrointestinal tract, as well as social problems. To recap, alcoholic liver disease is actually a chronic liver disease associated with chronic alcohol consumption. It is also a disease spectrum that encompasses a wide range of liver injury from hepatic steatosis to hepatocellular carcinoma. As I have mentioned previously, alcoholic liver disease can be divided into 4 stages depending on its severity. The first one, which is the mildest one, is called hepatic steatosis. It is also known as fatty liver disease, whereby the patient liver will be deposited with fatty tissues. However, the patient will remain asymptomatic and the condition is completely reversible if the patient stops taking alcohol. Even though the condition is completely reversible, 10% may eventually develop alcoholic liver cirrhosis. The next one is steatohepatitis, and this condition occurs when there is necroinflammation along the fatty streak in the liver. Steatohepatitis is associated with high short-term mortality rate, and in contrast to hepatic steatosis, 40% of steatohepatic patients may eventually develop cirrhosis. The third one is alcoholic liver cirrhosis, which occurs in about 8 to 20% of chronic alcoholics. The development of alcoholic liver cirrhosis is closely related to other factors as well. For example, the pattern of drinking, female gender, obesity, genetic polymorphism, and comorbidities. The last one and the most severe one is hepatocellular carcinoma. Hepatocellular carcinoma may occur in about 3 to 10% of alcoholic cirrhosis patients. The pathogenesis of alcoholic liver disease is multifactorial. It is related to ethanol metabolism, increased oxidative stress, mitochondrial dysfunction, hypoxia, impaired proteasome function, abnormal metabolism of amino acid such as methionine and S-adenosylmethionine, as well as abnormal metabolism of folate. It is also related to abnormality in the gut-liver axis as well as fibrosis formation. In chronic alcoholism, when the patient ingested alcohol, the alcohol will be absorbed through the intestinal epithelium into the portal vein, and then the alcohol will be sent to the liver and become absorbed by the hepatocyte. The alcohol will be metabolized initially by alcohol dehydrogenase to form acetaldehyde, and then the acetaldehyde can be converted to acetate by acetaldehyde dehydrogenase. Further, the acetate will be converted to acetyl-CoA by acetyl-CoA ligase, and this acetyl-CoA will enter the TCA cycle or Krebs cycle to generate NADH, FADH2 as well as GTP. NADH and FADH2 will enter oxidative phosphorylation to produce energy to the patient. And in chronic alcoholism, alcohol will become the major source of energy, whereby it provides 7 kilocalories for each gram of alcohol being ingested. In chronic alcoholism, because there is excessive intake of alcohol, not all acetyl-CoA will enter the TCA cycle. The excessive acetyl-CoA can also be diverted into fatty acid synthesis. So this fatty acid can be incorporated to form triacylglycerol, and in normal condition, triacylglycerol will be packaged into VLDL or very low density lipoprotein and is transported into the blood circulation to reach the peripheral tissue. Increase in triacylglycerol can also increase the formation of fatty tissues inside the liver itself, and the deposition of these fatty tissues in the liver will cause steatosis. Alcohol metabolism can also involve another type of enzyme called as cytochrome P450-2E1. This enzyme is located at the endoplasmic reticulum, and it catalyzes metabolism of alcohol to acetaldehyde and from acetaldehyde to acetate. In contrast to the previous pathway, this pathway using the cytochrome P450 will generate reactive oxygen species. And in increased amount of ROS production or in excessive ROS production, it can lead to damage to the hepatocyte. For example, lipid peroxidation of the cell membrane and organelle. It can cause protein damage, and it can also cause DNA mutation or DNA damage. In normal condition, when there is damage in any proteins, the protein will be tagged by a process called ubiquitination, and then is sent to the UPS system or ubiquitin proteasome system to be degraded. But in chronic alcoholism, the UPS is inhibited by alcohol. Therefore, the damaged protein caused by increased oxidative stress inside the hepatocyte cannot be degraded and will be accumulated in the cell, producing Mallory-Dank bodies. During the metabolism of alcohol, acetaldehyde will be produced. In chronic alcoholism, there will be excessive amount of acetaldehyde, and this acetaldehyde can enter the blood circulation and reach the intestinal epithelium. In intestinal epithelium, the acetaldehyde reduces zonular adherence protein at the tight junction in between the epithelial cells of the intestinal lumen, and because of the reduction of this protein, the intestinal permeability will be increased, especially to the toxins. In chronic alcoholism, Probiotics such as lactobacillus species and bifidobacterium species will significantly become inhibited. So when this probiotic reduces, the pathological bacteria, which is the gram-negative bacteria, will increase in their growth inside intestinal lumen. These pathological bacteria can release endotoxin, and this endotoxin can readily enter the blood circulation because of the increased intestinal permeability due to reduced zonular adherence protein at the tight junction. Endotoxin will enter blood circulation causing endotoxemia, and then this endotoxin will be transported into the liver and it will activate Kupffer cell to release reactive oxygen species as well as pro-inflammatory cytokines such as TNF-alpha, interleukin-1, interleukin-6, and interleukin-8. These pro-inflammatory cytokines will activate apoptosis, so there will be programmed cell death of the hepatocytes. Apart from that, this pro-inflammatory cytokine can inhibit VLDL release. So when VLDL cannot be released into peripheral tissue, there will be more accumulation of fatty tissue inside the liver, further aggravating steatosis. Increase in pro-inflammatory release by Kupffer cell can also cause damage to endothelial cells, and this damage need to be repaired. Stellate cells that is present in between hepatocyte will first transform to myofibroblasts, and these myofibroblasts will produce collagen, and this collagen in turn will be deposited to the damaged area caused by the damaged endothelial cells. When there is excessive amount of collagen deposition, the patient will start to develop alcoholic liver cirrhosis. This pro-inflammatory cytokine not only can cause damage to endothelial cells, it can also cause damage to hepatocyte itself. And when hepatocyte is damaged, the cell will be burst and the intracellular contents will be released out. And one of it is enzyme ALT, another one is enzyme AST. This enzyme ALT and AST can be released into the circulation, and in the patient of chronic alcoholic liver disease or chronic alcoholism, when we do liver function tests, we will see a raised or elevated level of the ALT and AST. In chronic alcoholism itself, the absorption of various nutrients will be impaired. One of it is the absorption of folate vitamin. Folate vitamin is important in the synthesis of methionine from homocysteine. So the amino acid methionine in a normal condition will be converted to S-adenosyl methionine, and this S-adenosyl methionine is an important methyl donor for all methylation processes of DNA and histones, which is important in gene regulation. So after the methylation process takes place, the S-adenosyl methionine will become S-adenosyl homocysteine, and it will be further metabolized to homocysteine. And homocysteine will be recycled back to methionine by the enzyme methionine synthase with the presence of vitamin B12 as well as tetrahydrofolate. So impaired absorption of folate vitamin in chronic alcoholism will cause impairment of this recycling process. Therefore, homocysteine cannot be converted back to methionine, and S-adenosyl methionine will be reduced in amount. Because of that, regulation of gene will be impaired and there will be further damage to the DNA. So the patient who are suffering from alcoholic liver disease will have various symptoms involving various organ systems. For example, the patient may have encephalopathy, cerebral atrophy, and Wernicke-Korsakoff syndrome. The patient may also have enlarged parotid gland, spider angiomata, hypertension, cardiomyopathy, and arrhythmias, liver cirrhosis, hepatitis or steatosis, gastritis, esophagitis, enlarged spleen, enlarged liver, pancreatitis, accumulation of fluid inside the peritoneal cavity causing ascites, diarrhea, testicular atrophy in men, reduce in bone density or osteopenia, and myopathy. Patient may also have neuropathy due to various vitamins malnutrition. Malnutrition in alcoholic liver disease is a combination between reduced oral intake as well as reduced absorption of nutrient from the intestine. So the patient with alcoholic liver disease will usually have nausea and vomiting. So when the patient vomits a lot, naturally the appetite will be reduced, leading to anorexia and poor oral intake. And apart from reduced oral intake, the intestinal absorption itself is reduced due to diarrhea and malabsorption. Apart from that, malnutrition occurs in alcoholic liver disease because of the treatment itself that the health practitioner gives to the patient. For example, if the patient comes with hepatic encephalopathy, the patient will be put on protein-restricted diet, which further aggravate malnutrition. And in patients with ascites, they will be put in low-salt diet, therefore causing the food to be less palatable and further reduce oral intake. The liver itself is started to become damaged, so the normal function of the liver to store nutrients as well as to utilize the nutrients will become diminished, and inflammation in alcoholic hepatitis causes the muscle and visceral proteins to be depleted, further aggravating malnutrition. The most important malnutrition in alcoholic liver disease patient is protein energy malnutrition. As the name suggests, in this malnutrition, the main nutrients that is lacking is protein as well as energy, for example, carbohydrate. So the prevalence of protein energy malnutrition is very high. It can be 20 to 60% of outpatients who are suffering from alcoholic cirrhosis, and it can be almost 100% in inpatient with alcoholic hepatitis. So basically, the protein energy malnutrition is very common with high prevalence in alcoholic liver disease. It is a result of imbalance between requirement of the body, intake, as well as utilization of the nutrients. And because of this protein and energy malnutrition, there will be altered regulation of nutritional status and energy balance by the liver as well as reduced appetite. Protein energy malnutrition predisposes the patient for complication, for example, encephalopathy as well as bacterial infections. And it also causes reduction in the liver integrity, because in chronic alcoholic liver disease, the liver itself is damaged, so repair process must be taken. But because of the protein energy malnutrition, the body will have less substrates to be used for the repair of the damage in the liver. Patient with protein energy malnutrition is usually associated with poor clinical outcome. Another type of malnutrition is folate deficiency, and as I have described previously, the folate deficiency occurs because of the reduced dietary folate intake intestinal malabsorption, reduced liver storage and uptake, as well as loss in the urine. So the folate is essential in the formation of methionine from homocysteine, and because of that, as adenosyl methionine will be reduced and various processes requiring methylation, especially DNA methylation and histone methylation, will be impaired. Folate deficiency causes impaired regulation of genes expression as well as impaired DNA synthesis and stability, leading to increased risk for developing hepatocellular carcinoma. Apart from that, impaired DNA synthesis can also cause development of megaloblastic anemia, whereby the RBC is unable to become mature. In animal model of alcoholic liver disease, when the animal is given large quantities of alcohol simulating the chronic alcoholism, it is associated with reduced folate transport across the jejunal brush border. So in animal model itself, it shows that in chronic alcoholism, folate absorption will be abnormal. Individuals fed with folate depleted diets along with alcohol develop significant reduction of hepatic metabolism and storage of folate. Apart from that, patients with alcoholic liver disease will have water-soluble vitamin deficiency, for example, thiamine or vitamin B1. Vitamin B1 deficiency is a well-recognized alcoholic liver disease complication resulting in Wernicke's encephalopathy and Korsakoff syndrome. In Wernicke encephalopathy, the patient will have triad of mental confusion, ataxia or imbalance, as well as ophthalmoplegia or reduced ability to move the eyeballs. And in more severe condition, the Wernicke's encephalopathy will be associated with amnesia or memory loss, and this is called as Korsakoff syndrome. Another vitamin deficiency in alcoholic liver disease is deficiency of vitamin B12. Vitamin B12 is important in the recycling of homocysteine to methionine along with folate vitamin. So deficiency of vitamin B12 indirectly affects the resynthesis of methionine from homocysteine. Patient may also have zinc deficiency due to decreased intake, malabsorption, increased dietary requirement, as well as diuretic regimen if the patient has ascites. And zinc deficiency is associated with various complications, for example, skin lesion, impaired night vision, altered taste and smell, immune dysfunction, hypogonadism, encephalopathy, as well as altered protein metabolism and delayed wound healing. Study by Zhao et al. And Sun et al. In 2005 and 2016 respectively showed that zinc supplementation in alcoholic liver disease mouse model will induce the activity of alcohol dehydrogenase, meaning that zinc supplementation will increase alcohol metabolism in the alcoholic liver disease mouse model. It will reduce activity of cytochrome P2E1, therefore reducing the ROS production, and it will also induces glutathione reductase activity, which helps in the detoxification of the excessive reactive oxygen species. In animal model with zinc deficiency, it is shown that the oxidative phosphorylation complex 1, 3, and 4 will be affected. Therefore, in zinc deficiency, ROS production will be increased because of the reduced activity of these OXPHOS complexes. In addition to deficiency of water-soluble vitamin, alcoholic liver disease patient may also develop fat-soluble vitamin deficiency, and it is because of impaired production of bile acid in the liver, reduced oral intake, as well as impaired carrier protein synthesis by the liver as well. If the patient has vitamin A deficiency, the patient might develop night blindness and abnormal dry eye or xerophthalmia. If the patient has vitamin D deficiency, the patient will start to have osteopenia and osteoporosis due to imbalance in calcium homeostasis. Vitamin E deficiency will cause reduced antioxidant activity in the liver, and it will further aggravate the damage caused by the reactive oxygen species generated in alcoholic liver disease patient. If the patient has vitamin K deficiency, the patient will have higher risk for developing spontaneous bleeding. It is because vitamin K is essential in the production of clotting factors 2, clotting factors 7, 9, and 10, protein S, as well as protein C. Other nutritional deficiency may include deficiency of vitamin C, magnesium deficiency, which can cause dysgeusia and further reduce oral intake, as well as deficiency of selenium. However, studies show that supplementation of these micronutrients remain debatable due to inconclusive evidence. The treatment for alcoholic liver disease is mainly alcohol abstinence, and that is the most important goal of alcoholic liver disease treatment. Study shows that after 3 months of alcohol abstinence, the patient will have improved in the signs and symptoms. After 2 years, the patient will have improved laboratory parameters, and after 3 years, the survival rate will increase dramatically to 70 to 80%. And in the past, disulfiram is an agent that is used to induce alcohol abstinence. However, disulfiram is associated with poor tolerability, and there is weak evidence that it increases abstinence of alcohol. Therefore, other agents are being studied to help in the promotion of alcohol abstinence. For example, baclofen and naltrexone. Baclofen is a GABA B receptor agonist, and in a study by Muller et al. In 2015, patients who received baclofen, about 68% of them successfully maintained total alcohol abstinence as compared to the placebo, which is only 23.8%. And baclofen is superior to disulfiram, in which there is no serious adverse effect associated with its ingestion. Another agent is naltrexone, which is an opioid antagonist. Study by O'Malley and the team in 2015 shows that naltrexone significantly reduces intensity of alcohol drinking, and apart from causing sleepiness, naltrexone also has no serious adverse effects. Other goals of alcoholic liver disease therapy is the nutritional support to reduce the malnutrition. The goal of nutritional support is to provide substrates for regeneration of damaged liver. It is also important to prevent, correct, and treat nutritional deficiencies, as well as to prevent, correct, and treat complications of liver disease itself. Nutritional support can be achieved by either enteral feeding or parenteral feeding. However, if the gastrointestinal motility is adequate, enteral feeding is preferred than parenteral feeding. Enteral feeding can be achieved through oral, nasogastric tube, or orogastric tube. This diagram shows how the nutritional support can be given to the patient. If the patient is fully awake and able to take food by himself, then the nutritional support is given through the mouth. If the patient is weak and impaired in his consciousness, nasogastric tube can be inserted through the nasal cavity down into the stomach, called as nasogastric tube, and nutritional support can be given through this tube. Some other patients that requires prolonged usage of nasogastric tube may be converted to the gastrostomy tube, whereby a tube is inserted directly through the skin directly into the stomach or through the skin directly into the jejunum. And nutritional support can be given through these tubes. These are called as enteral feeding or enteral nutritional support. In parenteral nutritional support, the patient is given extra nutrients through the intravenous circulation. I think that's all for my presentation. Thank you.